Hello everyone. Today I Dr. Abhinav Gupta, Director of Makino International Healthcare Private Limited. Basically Makino is having his chain of physiotherapy and rehabilitation centers throughout India in the name of Makino Care. Today we are going to discuss about multiple sclerosis. What is multiple sclerosis? I will explain you the disease, its risk, pathology, signs, symptoms, impairments, rehabilitation part, everything in detail, but in a very concise way that is useful to you as well as the students who are studying physiotherapy. Coming up to the multiple sclerosis. What is multiple sclerosis? It is the chronic progressive degenerative disease of the central nervous system, basically affecting the Schwann cells and the oligodendrocytes. Now coming up to the incidence. It is mainly occurring in the early 30s. That's why it is also known as the great crippler of young adults. The disease is highly unpredictable and varies from one individual to other. If we talk about the etiology, the common causes of the disease is genetic or the hierarchy theory. The second theory is, some people say that it is an autoimmune disease, and the most accepted theory is the viral infection that is occurring because of the MMR virus. Now, one more thing I would like to tell you about the disease is it affects white people more than the black ones. So the Britishers are more affected than the other population. Due to demyelination, basically it leads to the slow conduction of impulses. Okay, and as the disease progresses, the conduction blocks. Basically, MHC protein on chromosome number 6 basically protects these antibodies. Now coming up to the areas of predilection. What is predilection? That are the favorite areas of the disease which are getting affected by the this multiple sclerosis. What are the favorite areas? The optic nerve, the subcortical white matter, corticospinal tracts, and the cerebellar peduncles. Now coming up to the pathology. Pathology is basically characterized by the distinct episodes of neurological deficit which will occur separation with the time. Now basically due to pathology there is healing. It is a body's normal mechanism that when there is some pathology occurs, the healing occurs on their own. And when there is proliferation of astrocytes, by giving them granulation tissue forms, which finally leads to scarring. Now coming up to the clinical features of multiple sclerosis. Basically, it will affect the visual field. I will explain you the impairments organ-wise. For example, if we come to the visual field, visual problems, there can be nystagmus, that is dancing eyes. There can be diplopia, that is double vision, optic neuritis, and in severe cases, there can be blindness as well. The second most common clinical feature is fatigue. The patient will always be lethargic, which is basically due to delayed motor responses. Third one is sensory involvement will be there, paresthesias and ball and bladder impairment. Then trigeminal neuralgia. What is trigeminal neuralgia? It is the severe and stabbing pain to the one side of the face. Then balance and coordination problems will be there. Charcot's triad is the main classical symptom of multiple sclerosis. What is Charcot triad? As the term itself indicates, triad, that is the combination of three things: scanny speech, nystagmus, and the intentional tremors of the extremities. Now again, as I am telling you, corticospinal tract is also involved. So what symptoms will occur out of that? Spasticity will be there, deep tendon reflexes will be exaggerated, hermit sign will be there. What is hermit sign? Hermit sign is if the patient is flexing forward with neck flexion and lower extremity in extension, then patient will feel shock-like sensation in the spine. That is a positive Hermit's sign. Basically, why it is occurring? The shock-like sensation or the positive Hermit sign is coming in the case of damage to the posterior white column of the spine. Now, there are cerebral involvements as well, which will be like ataxia, dysdiadochokinesia, dysmetria, dizziness, vertigo. Okay. Other clinical symptoms what we can talk about is hyperpathia, hypersensitivity, stress during gait, psychological changes. In severe cases, there can be Marcus gun pupil, internuclear ophthalmoplegia can be there. What is the internuclear ophthalmoplegia? That is an adduction defect. Patient is unable to adduct the affected eye. When you try to adduct the affected eye, the eye will go downward. Then other visual impairment will include Scott mice. There is a blind spot in your visual field. Then chronic neuropathic pain will be there. Sexual imbalances can be there, which is because of the decrease in the level of libido causing impotency. Then other signs of multiple sclerosis includes Uthoff sign. Uthoff sign is some of the symptoms or signs which will exaggerate the symptom of the patient tremendously. That symptoms will include warm temperature, hyperventilation, malnutrition or sleep deprivation. If there is rapid change in patient's routine, that can aggravate the patient symptoms. Now coming up to the types of multiple sclerosis. Multiple sclerosis is basically divided into 4 parts. RRMS, relapse remitting multiple sclerosis, primary progressive multiple sclerosis, secondary progressive multiple sclerosis and progressive relapsing multiple sclerosis. If we talk about the relapse remitting, there are multiple phases of relapse and remit. The disease will come, go, come, go, come, go. It will follow a pattern. Primary progressive will progress like a flow graph. Coming to the secondary progressive multiple sclerosis, that will, once there will be episode, then there will be a relapsing period, there will be rest period, then there will be another period which will be more intense than the last one. And fourth one is progressive relapsing multiple sclerosis. Okay. Then coming up to the assessment of multiple sclerosis. If we talk about the PT assessment and management of multiple sclerosis, first what we have to measure is, what we have to assess is our neurological assessment is very important. In neurological assessment, first we'll start with measuring the cognition function or the cognition impairment. That will be measured by MMSE scale, Mini Mental Status Examination, which will measure the attention, understanding, orientation, recall, memory and learning of the patient. The maximum score for MMSE is 30 and minimum score is 23. If the score is less than 23, it will be considered as a problematic cognition function. Okay, coming up to the sensory examination. Sensory examination will include your superficial examination, deep examination and the cortical examination. In superficial examination, you will go for check for pain, touch, temperature. In deep, we'll check for proprioception, kinesthesia, vibration, pressure. In cortical, we'll check for stereognosis, barognosis, graphesthesia. Then coming up to the motor examination. Motor examination, the most important scale is tone assessment scale. We'll check the muscle tone of the patient. We'll check the DTRs, because in multiple sclerosis we should find exaggerated DTRs. In tone, what we'll find is hypertonicity, spasticity, which will be measured by modified Ashworth scale can be used. Babinski sign should be checked. Corticospinal tract examination is very important. Then we'll check the strength, endurance, cerebral function of the patient, and we also have to check the vestibular system involvement. Then we'll check the balance of the patient. Balance and visual assessment is very important. How we'll assess the visual part? We'll go for saccadic movement, pursuit movement and optic nerve movements. Now, then after the visual management, it is important to go for speech examination, speech assessment. Then for gait assessment, rate of disability scale. How disability will be measured? By Kreutzke scale or by quality of life questionnaire or by fatigue impact scale. All these scale can be used. And for functional independence measure scale, Barthel index, Kate index can be used. Coming up to the physiotherapy management. What will be the goals for physiotherapy management? The basic goal will be to improvise the quality of life of the patient. So we will bifurcate the goals as per the requirement. Likewise, we have to manage the pain. Pain management should be there. Improve motor function, improve posture and balance, improve skin integrity, improve gait. We have to reduce the secondary impairments associated with the immobilization. Then we have to improve energy consumption, improve balance and coordination. We have to maintain fatigue. We have to then make the patient functionally independent. Now coming up to the fatigue management, how we are going to manage that. We are discussing the plans. So for fatigue management, there must be regular pacing. Patient should be given regular rest intervals between the fatigue. Then coming up to the pain management, if we talk about, avoid the factors that can cause pain. Likewise, neck bending, warm temperature, insomnia, malnutrition. Soft tissue manipulation can be given. Likewise, Ifraj in cases of trigeminal neuralgia. Relaxation exercises can be given. Cervical collars should be given to prevent hermit sign, that I have told you earlier, that it is causing shock-like sensation in the spine because of neck and the spinal bending. Then TENS can be used for pain relief. Tactile stimulation can be given. Cryotherapy. Multiple methods are there that will be customized as per the requirement of the patient. Coming up to the management of spasticity. There are multiple things available in market, but most common things that we use for spasticity management includes PNF patterns, maintain antispastic position, slow sustained stretchings, neurodevelopmental techniques, passive stretchings, reciprocal inhibition techniques, rhythmic stabilization or rhythmic movements we can say techniques, bracing, casting, load bearing exercises, single leg standing or serial casting, or nowadays the most common concept is hydrotherapy that is coming up in knowledge. Hydrotherapy is basically making the patient exercise in warm temperature, that will decrease the impact of spasticity. Then cryotherapy can be used, which decreases your NCV. Then coming up to the after cryotherapy, hippotherapy can be used, which is the horse riding, which includes the improved postural correction, improves adductor muscle stretching, helps in pelvic mobility, gait immature, and the mat activities such as like bridging, which can break the abnormal synergy of the hip and the knee. Then what we can include is NMES and FES. What is the basic difference between the NMES and FES? NMES is neuromuscular electrical stimulation and FES is functional electrical stimulation. If we are training a particular complete function, then we can go for FES, and if we are training the isolated movement, then we should go for NMES. Then coming up to the sensory, there are two approaches what can be commonly used for sensory, that is the compensatory and the remedial approach. If we can rely on another system to compensate the damaged system, we can go for compensatory approach, and if the system can be re-educated, we can reuse the system which is damaged. Okay, remedial approach can be used. Okay. Then coming up to the skin care. Skin care comes under the prevention of secondary complication. That will include prevention of pressure sores, use of pneumatic beds, use of air beds, pelvic bridging exercises. Basically, what is the purpose? To relieve the pressure from the bony prominences. We have to keep the patient clean and dry. We have to make the patient wear clean, comfortable clothing. Less strain exercises should be given. Careful transfer of the patient. Usage of mirror for self-inspection. Then coming up to the gait mobility. Whatever gait mobility will include, that first of, as I have told you in spasticity, hippotherapy can be used to improve gait mobility, as it is improving postural control, it is improving adductor muscle stretching. It is also helps in pelvic stability and mobility as well. Then movement in front of mirror can be done. Assistive devices can be given to the patient as per the requirement. To prevent falls, the attendants and everyone should be guided for how to transfer the patient, how to use the wheelchair, bed to wheelchair transfers, wheelchair to bed transfers, supine to sitting, sitting to supine, and multiple positions are there. Another part of gait training in modern technology, what we are using is harness supported treadmill walking, in which we improve the confidence. Basically, when the patient is walking with the help of a harness, the confidence of the patient is at different level that he is able to walk. We can also strengthen the antagonist muscle. It helps in reduction of spasticity as well as the improvements of balance. Now coming up to the visual problems management of visual problems, that will include use of tinted glasses, eye patches, or the prism glasses, which can be used for diplopia, eye strengthening exercises, gaze stabilization exercises, and the psychological support is very important for the patients with multiple sclerosis. But the management is very broad. The physiotherapy management is very broad for the patients with multiple sclerosis. It will also include the speech therapy. Basically, what part of speech therapy can be covered by a physiotherapist is oral motor muscle exercises, lip closure exercises, jaw control exercises, tongue movements, speech therapy, and we also have to maintain the cardiorespiratory function of the patient by telling them to for exercises for breathing. Then cognitive management will include the improved memory. What we can do is we can give them timing devices, same time, same therapist, same place, for making the patient more comfortable. Then coming up to the management of balance and coordination, how we can improvise the balance of a patient with multiple sclerosis. We'll go for usage of balance boards, weight shifting exercises can be done, physio ball can be used, single leg standing, tandem walking, parallel walking bars can be used, and mirror therapy can be used. Then further exercises can be Frankel exercises, habituation exercises can be done, and this basically habituation, vestibulo-ocular exercises are for training of vestibular system. Then force biofeedback is the new technology that is being used nowadays, that is having screen and the sensors to maintain balance of the patient. Agility exercises can be done, coordination exercises can be done, orthosis prosthesis can be given, assistive devices can be given, weight cuff, balance based torso-wing is another concept that we are using nowadays, and strengthening exercises of the anti-gravity muscles, that is gluteus maximus and the tibialis anterior, is also a very important part in the rehabilitation of multiple sclerosis patients. So students, friends, this was the detailed physiotherapy assessment and management and the introduction about the disease multiple sclerosis. Any further question you can post in your comments as well as to our email, that is healthcaremakino@gmail.com. Thank you.